So let's have a think then. What I was going to dance then. Do, 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 do. I know. We could do that. Do that later. So there's lots of chitter chatter. So anybody want to share some of the things that they've learnt today? Oh, someone's pressing their phone. Oh, it's Simon. Hi, Simon. Right. Has anyone learnt anything apart from me? Go on.
So I'm from a secondary care background, and thank you. Sorry. And I was thinking about the trauma-informed dentistry, and that there's departments within my hospital in gastroenterology and in surgery that things are put in people's orifices with or without sedation, and no real consideration of what those kind of aspects might be. And that's an area that I think maybe it could be thought about what we might want to do there. So that was one thing.
So yeah, that kind of trauma-informed care, kind of the more medical interventions we do and the less choice people have when they're being undertaken can have all sorts of ramifications. So I think there's lots of areas of medicine that we probably just get on with it, don't we? And that might be quite difficult for people. So I think that's really interesting. Anything else that people have learnt today? Oh, good.
Well, we had lots of wide-ranging chats about lots of things, but I think the thing that I took away was and others have been no hard-to-reach groups. Yeah. That really resonated with me, because I think we do put people in a box of, we can't reach them, it's difficult, but it's definitely about access, isn't it? And like how the service is set up for their needs rather than for our needs as providers. So I'm definitely going to be taking that one away.
Yeah. No hard-to-reach groups, that was a great tagline, wasn't it? Said with full passion. Anyone else got anything they've learned today? Oh, come on, there was loads of chit-chat until I get the microphone out. Oh, good.
We had lots of different discussions, because there are people who are probably more new into this role and people that have been here for a long time. But I think the one that that we all had learned from was the soothing and the alert model, where we were trying to put that into practice, and how we already do that, but then referring it into the ways of the working and terminology to patients for saying, the appointment types that we think we'd all took that away. And then the CAN group, we said, really good work that I think gets missed in the networks. The trauma-based dentist, we hadn't heard of that. And then the stress and the links to asthma was a really good presentation that we'd all learned. So a few bits.
Cool. Anything else? Oh, Liz has always got something. Oh, sorry, I said that, didn't I?
You'd miss it if I didn't say it. No, only that oxygen is the only molecule you should be breathing.
Thanks, Liz. No further comments. Cool. So some of those things that you learn are kind of interesting, isn't it? And we deliberately, when Sam put today together, we tried to make it broad so that there would be different things that we could engage with and just stretch our thinking. So before we have coffee, the next thing I want you to do is, on your tables, is think of a story of a patient you've seen if you're a healthcare professional, or someone you know in your community, or someone you've worked with that's really bothered you. So I often think change comes from the stories that just unsettle us. I love stories. And the patients that, I really like the patients where I know the diagnosis and I get it right, because I'm like, woohoo, I read some textbooks. And the patients that are kind of complicated but have dignity, I'm okay with. Do you know what I mean? The kind of people who are dying and they die well and that kind of thing. And then there's this whole group of patients that just niggle me. So I just want you to talk together about patients or stories that niggle you and why. And sometimes you don't know why they niggle you, but chatting together can sometimes help. Is that all right? Then we're all going to have coffee, and you're going to come back, and then we're going to talk about the PCN stuff really short, and then we're going to look at what can we do in a PCN. So we're going to pick one thing, And if you're in an imaginary PCN, this would be a great PCN, by the way. I would be in that PCN. But if you're an imaginary PCN, then you can pick something, because, if you even just look at the presentation we've had today, we've had, dental prevention, asthma, lots of things we could pick as our thing for health inequalities. And then we're going to think about what we can do to improve that. Is that right? So, but before that, the patients or the stories that have niggled you. Is that all right? And we're going to have dancing music whilst you're niggled. Is that all right? And then we're going to have coffee and then come back. Right, let's have a little check. Have you all ordered your dinner on delivery or something? So, has anyone got any ideas that they'd like to try? No one dare speak. Oh dear. Yes.
Yeah, so we'd like to set up something for patients to help them with their diet and with what they're eating, because it has come up in quite a few talks, the asthma talk and everything really. So, yes, not quite sure exactly how that's going to happen, but yeah, some kind of patient support group. People thought initially people with diabetes to help them think about what they're eating and ideas to what they could eat and how they can cook and how they can shop and all the rest of it. But as a side effect, also the weight would probably go down as well, but then also their mental health hopefully would improve, and skin and joints and asthma and all the rest of it. So we thought maybe about some kind of maybe group consultation, or possibly some kind of cooking club or something like that. So they learn the skills as well of cooking and knowing what to buy and what to eat. What else did we say? Yeah, that was kind of it really. Just a bit vague, but yeah.
I think there's quite a lot we could do around food. We have definitely had a cooking club in the past. The side effect of that is you get lunch cooked by them, which is great. So we did it in our upstairs room in our surgery, got a little electric 2-hob thing. So it wasn't particularly fancy. Turn the smoke detector off that day in that room. And yeah, I mean, we definitely had a cohort of patients who came, had fun, did it. There's a couple of things about it, is that you don't have to have massive numbers. So when you look at your diabetes list, there's one surgery that I look after that I think there's over 560 diabetics or something. And when you think about 560, it's just overwhelming. And then if you think, well, I'll get 5 people to my cooking club, you can think that is a drop in the ocean. But it's interesting because that does have a knock on, and it also has a knock on to your staff. So the people who are in the building are more diet aware. It at least happens once a week. The building smells nice. There's a kind of easy recipe that's shared around. It can go on the website. So there's stuff that kind of ripples from that, even if it looks like there's 5 random people cooking dal. Do you know what I mean? And it's a start, isn't it? And I think some of these are just small starts, isn't it? You can use the R's money for dietitians. You can use some of the care coordinator roles. Clinical coordinator roles can be used for quite interesting stuff around diet, and wellbeing coaches are all in there. So if in a PCN that hasn't got an R's plan, which most of them in Greater Manchester don't, that's something to look at. So there. But yeah, definitely have a go. And the other thing is that you can work with lots of third sector organisations. There's a wonderful third sector organisation called Cracking Good Food, that's the one. And they'll come and do sessions for you in your surgery to kind of get you going, and then they'll help you start off. So yeah, that was I think that's a goer. As ideas happen, I think that's a goer. Yeah, any other ideas? Oh, and everyone's really nervous now, aren't they? Go on, Alan.
We had a few different ideas, from apps to using Alexa, but one thing I thought that I would like to explore really on leaving is this concept of threat and soothing. We did as a CCG have an exercise before where we opened up the chimp paradox and learning to all practices. And I wonder if we could do something similar at a practice level or a PCN level for soothing, so that our practices could become soothing practices.
Yeah, it would be really interesting, wouldn't it? How do you become a soothing practice? I'm really intrigued by soothing. because it feels more doable than resilience to me. Like resilience means somehow I'm going to be a marathon runner and then my muscles won't ache the next day. That's kind of, just have to work harder and get better and more resilient and work harder. And I think soothing for me gives permission to not do stuff, to slow down a bit, and just those thought processes. I heard Jen's talk a couple of months ago, and even in consultations, realizing that I'm acting out of threat or drive, and the patient's acting out of threat or drive, and then we're making each other get more and more like, and just even me going, just breathe, even like telling myself, just breathe, has shifted stuff in me, even hasn't, and I think it then shifts in other people, doesn't it? So, yeah, how do you become a soothing place? Particularly for our receptionists, I think our reception staff are absolutely battered some days. So how do we create a space for soothing? Generally, I think that's really interesting, yeah. Be nice, wouldn't it? Don't buy lavender though, will you, Alan? That's what they did in A&E. In the middle of COVID, Captain Tom was there with his walker, and we got some lavender. I was like, it's not really going to help, is it? Let's be honest. Anyway, any other ideas? Yeah. Of course it's not fully formed. I had 10 minutes.
We wanted to sort out our new mums. We wanted to help them out because we were worried there's quite a lot of new mums who had a lot of issues in their lives, and we were reflecting on how important that birth to 1 year is in terms of development and the knock-on effects as a result of that, and any trauma that might have been experienced at that. In terms of how we were going to do that, we're a little bit unsure, but one thing we were thinking was, could we have kind of a named professional or worker who would be assigned to all new babies when they're born, and it was sort of, they could then follow them up, and could act a little bit like kind of shared care and do some signposting or some sort of more in-depth things. We also wanted to make sure we could do it from the perspective of the new mums as well, and maybe have some peer support, because what we think might be important for new mums might not be what they think is important. And there's probably some value in having someone who's gone through that process and who is a new mum themselves, being able to model that. So yeah, that's sort of where we were at. What did you say? Sorry, parents? Oh, and dad. Well, that's a good point, actually. I didn't even mention about the dads in this, but yeah, we were quite focused on the mums. But yeah, any other suggestions around that would be helpful. And yeah, exactly, yeah. So it's going to be based on what we were finding the needs were from that cohort of people.
Yeah, I think new mums is really fascinating, isn't it? Like I feel, I'm not looking at Alan now, I feel quite old. But like we've had Sure Start, we've had, do you know what I mean? And it comes and goes, doesn't it? And it does feel at the moment there isn't an awful lot for new mums, I have to say. And it's such a difficult time, isn't it? I think it's the consultation I love the most is the crying new mum. I just love it. It's like my favourite consultation to do, because very rarely is the baby sick, are they, really? But it's just, and I was a crying mum. I did a lot of crying. So I feel like I can do that one. And it just makes such a difference, doesn't it? So I think having something for young mums is really cool. Whilst I'm yabbering on, should I tell you that when my first was born, I was quite young and I lived in Fitton Hill. And so I kind of got categorised with that. And Barney cried all the time, like all the time. And I think he probably had this thing called reflux. Nobody told me about that. So the health visitor sent me to baby massage that was on at the time. So I went to this baby massage centre and took off all his clothes and was massaging away. And obviously I was probably quite tense, like up here. Anyway, this squawky thing, who was twice the size of all the other babies, cried and cried and cried and cried and cried. And the woman said, I think you're upsetting the other baby. It's probably best you don't come back next week. So I tell him that he was expelled at 4 weeks old. So yeah, but what's interesting is I never went to a baby toddler group again, ever. Not even with the other three. It was could not go in. Even though the two were better behaved. So, but I think looking after new mums, isn't it? We know, don't we, the first 200 days is so important. We know increasingly that our health patterns are set when we're young. We know the mental health of our mums and our dads is really important. So yeah, anything I think anything that can help young mums is helpful, isn't it? Even if it's like, can we have a member of our practice team just ring them every fortnight, be like, are you okay? They don't have to be medical, do they? But just a nice, kind person going, we still know you're alive. Are you still alive? Oh, good. You know, I don't think it has to be massively medical, all this stuff. You know, can we do a toddler group in the waiting room? We've definitely done them. You have to disinfect the toys, but you know, there's lots of things that are very low cost. I think we can do that, at least help a bit. But yeah, if you in public health could allocate a key worker for every new mum, yes, go for it, sort it out. Yeah, yeah. Just contact, isn't it? Contact that's caring is really helpful. Oh, this is good. Yeah, you can immunisation them on the way. Anything else? Any other ideas? Go on, Michelle. Go on, be bold. Simon's not here, he'll never know you said it.
I don't like talking in a microphone, but I don't mind. So we had a couple of ideas for different health needs, and there's quite a diverse population in Oldham South. So we went with the idea that we do targeted health promotion on a monthly basis. And we would work with people like Focus Care and Action Together to go out to the groups and promote things like smears, childhood immunisations, and work with those community groups to promote it within those community groups. So I can't remember what was one of the groups. The Asian Women's Network and the Romanian community. Real CIC. I don't know all these organisations yet. And the dads, yeah, working with dads and new parents as well. So it would be a rolling monthly programme that we would promote as a PCN.
I think that's an easy win, isn't it? Yeah. I think that's doable. Don't you? Have a monthly cycle of like the groups are all there, big campaign across all the practices. This month is smear month. You know, drop in smear clinics, turn up, get a free sticker. I don't know, what would you want? Maybe not.
Surgery. So we were saying that to go out and actually speak to those ladies and reassure them that, you know, we can put extra screening up, we can make sure it's a female, we can do whatever it is that they want that will make them feel comfortable to come and have their smears done. The same with immunisations. We were saying that we would target, so a lot of the groups that we've got in our areas are targeting families that, you know, live in extreme poverty and things like that. So we would target those groups because they're already up and running. They've already got a good following of people that we want to target. So we would go in and actually speak to them on the ground and say, look, this is, you know, and explain it to them, because sometimes it's just that they don't understand. And we were saying about with the COVID vaccine, that's caused some uncertainty now, which will knock on for other vaccines. So it might just be that you go out and you have a conversation with them about childhood immunisations and give them a bit of, you know, and then they can understand it and they get it better.
There's no reason why people have to come in. So like you can do smear clinics anywhere. It's very low tech actually. You can do immunisation clinics anywhere, as we found in COVID. Like, we never thought you'd do an immunisation clinic in a cathedral and in the shopping centre, and we did. So some of this is even like, you know, I think there's real value in going out. If you've got a women's group that meets on a Wednesday anyway, can we do their smears whilst they're also doing whatever else is going on? Because that barrier of coming in is still coming into our space, isn't it? And actually, if you think about the trauma-informed stuff, coming into our space is part of the dynamic in it all. So there's lots of things to try, isn't it? It's kind of, when I talk about smears, I talk about the kind of probably 50% of women who just need lots of reminders to come. Then there's like 25% of women who need a conversation. That's probably normal primary care. And then there's a cohort that needs something else, isn't it? And the something else is often quite different. So, you know, over the years we've done like henna and smear day, which bizarrely went well. Come and get some henna, have a smear done. You know, we've done stuff out at other locations. We've done smear clinics where everything else is closed. So, you know, come on a half-day closing, everyone else has gone off to training day, and it is just very quiet. One person in the, you know, a receptionist and one person in the building, and there's no one going to see you. There's lots of ways of doing it that's manageable when you get your cohort smaller. So you've got to do normal primary care well, because you've got to get most people through the bulk of the normal system, and then it's all these bits on the side that are helpful. Cool, yeah. So I like that. Rolling propaganda, no, rolling programme. Lots of engagement, working with community organisations. Yeah, right, anything else we can do? Any other ideas? Is that a no? Well, you wanted to remake the whole of the A&E system. I thought that was a little ambitious for 10 minutes. Right, go on. Right, go on then. You like your idea, good, go for it.
Other people might not, but I like my idea. I just think that there's a certain amount of patients that keep coming through the door, keep using appointments. For example, body aches. There's something else going on. The GP never gets a chance to actually spend the time to find out, well, what actually is going on. So something like, obviously, maybe a coffee morning, a regular meet, a regular drop-in, where you can target these people and say, come and have a coffee. You have relevant people in the room that are trained to actually recognise what's going on or can talk to them more professionally, but on the surface it's just a coffee morning. Come and have a coffee with your practice staff. And then if they're regularly coming in, I think then as the conversations go, you can actually start to unpack and de-layer what's going on, and then maybe help these people go down a path that they need to go, rather than just come back again for body aches and things like that. Because then we're on using so many appointments for the same thing. There's a limited amount the GP can do in that 10-minute slot, but there's more going on.
So the recurrent patients are really interesting. So if you have, I think if you have a conversation with clinicians about recurrent patients, and a group of clinicians broadly decide that everything's been done, then you know there's very unlikely to be anything really sinister. So then you do need a different tactic for them. And that tactic is not often medical, actually. So things like coffee mornings and social clubs and is all really helpful. And you tend to get small numbers, but they can be really effective. I love the underground coffee stuff, because often some of these women really struggle to come out without the excuse of going to the doctors. So if you do a coffee morning that they can tell everyone they're going to the doctors, they're allowed to come. They can't come just for a coffee morning. So there's a few things you can do that there is, and you don't necessarily need a doctor in the room. You need someone who yabbers away and talks rubbish. No, yeah, gets people talking, and often it's connection and anxiety and purpose. And we have a really funny one at Hollinwood, which is a bunch of guys who are all alcoholic. They're still all alcoholic, but they come and they do the gardening at Hollinwood, and they are planning. One of them works for Parks and Gardens and has promised them all a decent pot in the cemetery. Anyway, but it's all very strange. But, you know, medically, their car crashes. They're not any closer to giving up alcohol, but they do come and they do grow things, and then they give their vegetables that they grow to friends. And it is like a dysfunctional, functional group. And that is actually quite important. There's nowhere else they can do that. So, you know, it's not very good medicine, it's small numbers, it doesn't change your population health quaff thing, but it's safer and they are better. And they do have less appointments for weird and wonderful things. So, good one. Any other ideas? Any other ideas? Go on, Liz. You don't need it, no.
Yeah, you don't need a big space to make a garden. At Hollingwood, there are just literally a few raised beds. It's probably only about, 3 metres by 5 metres. It's not big. And the veg that they grow makes the soup that they then have for their lunch.
So at Hilltop, they had this gardening project come, and I didn't realise what happened, but they put these like big bits of cardboard down and covered them in soil just in the middle of the grass. And when I went, it looked like these 2 graves had been dug. I was like, crikey, what have we done? Anyway, apparently it's a gardening project. Yeah. Right, I've got another idea over here.
We were actually talking about it at teaching for our training program the other week, but it's a larger scale piece of work about coding and the computer systems in place for gender identity for trans healthcare. EMIS is not great for that, and at the moment pretty much the only way to flag it up is a horrible term, but is to put an alert on, which doesn't feel humane and isn't very safe. So it's a much larger piece, but at some point that's something that we were talking about.
Coding, brilliant, yeah. And transgender stuff. So coding generally is your friend. So I like little coding projects. Coding things helps you find them again. So even coding, there's lots of wonderful codes on EMIS, but even coding like at risk of social exclusion, just little helpful things, you can find them again. It's quite helpful. So yeah. Any other projects we want to do? So the final one that I'm going to tell you must do is immunisations. So just in GM, we've dropped below herd immunity, haven't we? For the first time in quite a long time. So immunisations is a real pickle at the moment, and I think that's one that I'd really like. I think PCNs would be really interesting to talk about. So if we talk about the cohort, how many kids have we got to see that we just need to keep getting our receptionists to ring, and we need to get our nurses to ring, and we just need to normal general practice? How many of them actually require somebody to go and door knock, somebody from their community to go and door knock? Have we got vaccination champions in our Roma community, in our Bengali community, in our whatever? You know, we need to kind of be mobilising, don't we? And that's across GM. It's not just sunny Oldham, but immunisation is one that would be great for a health inequalities project. Cool. So I think we're going to come to the end of our day. Is that all right? You can all dip under the traffic. Has it been useful? Yes. Okay. We have a think about it. We were thinking about whether we do this again later in the year, mainly because it just provides a space for people to think and learn, but we don't want to do anything that people don't want to come to because it's a waste of time. But so have a think if you think it would be useful later in the year as we head, not maybe in September before we head into winter madness, but things. And the final thing to say is that the team from Shared Health have been amazing. So Sam, who's pulled the day together, thank you so much, Sam. And generally, if you want some help with health inequalities, you can contact the Shared Health team. So what they're really good at is finding solutions for like pickly problems that will help your project move. So there's a little bit of funding, but more than that, they're really good at going, okay, you need someone to employ those people. You need this kind of practical stuff done. You want this bid to be read. You want, all those kind of things that actually at PCN level, there's no one there to help do that, or PCN managers feel a bit overwhelmed. So they're kind of really good at sorting that out and putting support around projects to kind of make them grow and work. And you've seen some of Jen's stuff today and some of the other things. So feel free to contact them. Feel free to use them. They're there to be used. And yeah, thank you so much for coming. We've really enjoyed it. And I'm generally really chuffed that people turned up because it's it's always a good thing. So thank you so much. And yeah, we'll catch up with you all soon. Thanks.